Today, we'll be looking at reproductive psychiatry. My name is Dr. Boakye-Boama. I'm a medical doctor and a resident in the psychiatry department, Kumasi, Ghana. My email is peterboakye-boama27@gmail.com. We'll be starting with gender identity disorders. What is gender? Gender is the sense of being a male or a female. Mostly, the gender corresponds to the anatomical sex, that is, a man with male body organs, and also considers himself as a male. The same applies to a female. The following are the types of gender identity disorders. We have three main types. 1. Gender identity disorder of childhood. With this one, it usually starts in the preschool years. The child shows preoccupation with the dress and activities of the opposite sex. The child also expresses the desire to be of the opposite sex and rejects behavior, attire, and attributes of his anatomical sex. Usually, there is no feeling of rejection of the anatomical structures. 2. Transsexualism. This occurs in adolescents and adults. Here, the patient manifests a desire to live and be treated as the other sex, usually accompanied by a discomfort with one's anatomical sex and a desire to change, usually with the help of surgery or other form of treatment. The third one is dual role transvestism. Here, the patient wears the clothes of the opposite sex to enjoy the temporary feeling of belonging to the other sex. Unlike transsexualism, there is no desire to permanently change the sex, and there is no sexual arousal associated with cross-dressing. Treatment of gender identity disorders. In patients who insist for sex change, sex reassignment surgery can be done. Now let's look at disorders of sexual orientation. It must be remembered that homosexuality is not a psychiatric disorder. That is, the individual accepts his or her sexual orientation. Now, disorders of sexual response. Let's look at the phases of the sexual response cycle to be able to understand the disorders of sexual response. There are about 4 phases of the sexual response cycle. To begin with, we start with the desire phase. That is 1. This is characterized by a desire to have sex. 2. The excitement or arousal phase. This phase is characterized by penile erection and vaginal lubrication. 3. Orgasm. Here, there is speaking of sexual pleasure, followed by release of sexual tension and ejaculation of semen. The fourth one is resolution. Here, the body goes back to the resting state. Now, the disorders of the sexual response cycle. 1. The sexual desire disorders. This can be categorized as hypoactive sexual desire disorder, characterized by lack of desire for sexual activity. And 2. Sexual aversion disorder, characterized by active aversion and avoidance of sexual activity. 2. Disorders of excitement or arousal phase. In males, there is erectile disorder called erectile dysfunction. This is characterized by recurrent or persistent inability to attain or maintain the erection required for satisfactory sexual intercourse. Treatment is usually with PDE5 inhibitors, that's phosphodiesterase 5 inhibitors. Examples are sildenafil and tadalafil. The next one is female sexual arousal disorder. This is characterized by inability to achieve adequate vaginal lubrication required for sexual intercourse. The management involves the use of lubricants during intercourse. The third phase, that's disorders of orgasm. In males, we have premature ejaculation. It is characterized by a pattern of persistent or recurrent ejaculation with minimal sexual stimulation before or immediately after vaginal penetration. This is managed with the squeeze technique or the start-stop technique. You can read the details over here. We have female orgasmic disorder, that's anorgasmia, under the orgasm phase. It is characterized by recurrent delay or absence of orgasm in females. It is a common sexual disorder in females and treatment involves psychotherapy. Under the orgasm disorder, we have male orgasmic disorder, also called retarded ejaculation. It is characterized by recurrent delay or absence of orgasm in the male. It is commonly treated with psychotherapy. Other disorders include dyspareunia. It is recurrent or persistent genital pain in either men or women before, during, or after sexual intercourse. Another one is vaginismus. This is involuntary muscle constriction of outer third of vagina, which makes penile insertion difficult. The next one is nymphomania. This is used to describe excessive sexual desire in females. Then satyriasis. This is used to describe excessive sexual desire in males. Let's look at pseudocyesis. This is the firm belief in a female that she is pregnant, and the female usually develops objective signs of pregnancy such as abdominal enlargement, menstrual disturbance, fetal movements, uterine enlargement, and sometimes a positive pregnancy test in the absence of pregnancy. Treatment is usually supportive or insight-oriented therapy, and a trial of antidepressants can be done. Let's look at childbearing in patients with pre-existing mental disorders. For schizophrenia, patients who remain on treatment are less likely to relapse postpartum. But for bipolar disorder, two-thirds of women will experience a relapse of illness postpartum. You can read for the other disorders. Baby blues. This is a short-lived period of tearfulness and emotional lability that usually starts 2 to 3 days after giving birth and usually lasts for 2 days. Postnatal depression. This is a significant depressive episode temporarily related to childbirth, occurring within 6 months postpartum. Management usually involves education, support, appropriate pharmacological intervention with antidepressants, and preventing harm to the baby. Admission may be required. Postpartum psychosis. This is an acute psychotic episode that occurs 2 weeks postpartum. The common clinical presentations are three. We have one, prominent affective symptoms, which constitute the majority, schizophreniform disorder, and acute organic psychosis. Management of postpartum psychosis involves identification, education, support, treatment of at-risk individuals, hospital admission, and in the hospital admission, ECT, mood stabilizers, antidepressants are usually done. Psychotic symptoms are also treated with the usual protocol. Sexual dysfunction. Despite disagreement about what constitutes normal, there is general consensus that sexual dysfunction is present when there are persistent impairments of normal patterns of sexual interest or response. We treated this under the phases of the sexual response cycle. So I'll move through the slides and you can pause and read them as you wish. Now let's look at disorders of sexual preference. We have fetishism. Here, the person's sexual arousal or objects are non-living things such as clothing, shoes, or rubber. Then fetishistic transvestism. Here, the person's sexual arousal is with cross-dressing, that is wigs or makeup. Then exhibitionism. Here, the person's sexual arousal is with exposure of genitals to strangers. Then voyeurism. Here, they enjoy watching others who are naked. Then pedophilia. They are obsessed with children. Then sadomasochism. Here, their sexual arousal is with being humiliated, beaten, or bound. Then multiple disorders of sexual preference, that's where the individual manifests multiple disorders. Disorders of sexual preference management. Treatments should not be imposed on people who do not want it. Specific treatments include neurosurgery and bilateral orchidectomy, that's castration, psychodynamic psychotherapy, and CBT. Other treatments include non-medical treatments include facial hair removal, voice training, and supportive counseling. Endocrine treatment can also be done. Surgical treatment is considered in some countries. Some female feminizing hormones used are estrogen or androgen suppression. Some masculinization hormones include testosterone, and it's important to monitor and do some labs when doing sexual reassignment. Thank you. As usual, our quote is protect your mind, for it is your home. Thank you very much.